Good morning, everybody, and welcome to this meeting in public of the Board of NHS England. We're meeting here in London. We have members of the public in the room with us, and we're also, of course, live streaming the meeting. Entirely consistent with our view that the public of this country are entitled to see the way in which deliberations and decisions are taken by the Board on behalf of the patients and population that we serve. I have no apologies for this month's meeting. We have a full turnout of everybody. I'm going to invite members of the board to declare any agenda items where a conflict of interest may occur. Now, I preface that by saying that we have, of course, a register of interests that everybody has, and everybody has their own entry in that register sitting in front of them right now. Please, could you ensure that that's updated regularly? But secondly, specifically in relation to items on the agenda today, are there any interests that people would wish to record?
Yes, I'm a board member of ICOM, which is a digital provider to the NHS.
So that's in relation to our item on primary care and digital first. Okay. Are there any other interests you would wish me to record? And please feel free, of course, to raise them should the conversation inadvertently veer off in a direction which comes close to colliding with an undeclared interest. Good, thank you very much. We're going to have two additional attendees this morning. Dominic Hardy will join us on the General Practice Services Programme update, and Neil Churchill, Director of Experience, etc., on the People and Communities Task Force. One formal announcement, which I always have to make, is there is no fire alarm test due during the course of the next couple of hours, so if it does go off, our expert team will escort everybody safely off the premises. It will not be a test. Right, so let's get stuck straight into the business of the meeting. The first item is the minutes of the previous meeting. Can I just invite my colleagues, first of all, to confirm or deny that these are a fair and accurate summary? You're happy with that? And are there any matters arising from those minutes which are not otherwise on the agenda for today's meeting? No? Okay, thank you very much. Let me then go straight to the Chair's report. I have filed a written report, which I hope is sufficiently comprehensive to give people an idea of what's been going on over the last few months since our last meeting, focusing particularly on future funding for the NHS, and we will no doubt be touching upon that again this morning. Development of our plans for closer working with NHS Improvement, which is an active programme, and the board have been in strategic sessions working very closely with the Board of NHS Improvement and with their senior directors to try to understand how this complex and quite challenging process, which is not a full merger, but which is nonetheless trying to draw together as much of our central activities as possible to reduce duplication and overlap, but also give a strategic lead around integration across the whole of the service. And then also I've made mention of the rollout of the genomic medicine service. I just want to touch also on the resignation of Paul Baumann as our Chief Financial Officer, which has come, I know, as great news in the Baumann household, but not great news around the board table. And Paul, we will miss you enormously. This is not the opportunity for us to farewell to you, because you will be with us, we hope, until the end of October. But to congratulate you on that appointment, but also to assure the board that arrangements are now in hand for the search for Paul's successor, which is a critical appointment, particularly in the context of what I've just been talking about, which is the closer working between NHS England and NHS Improvement. So I won't say anything further on the written report, but I would like the board to join me in congratulating those members of the staff of NHS England upon whom honours were conferred in the Queen's Birthdays Honours List at the beginning of June, and in part in recognition of this fantastic institution called the NHS in England. The names that I'll read out very briefly: Yvonne Coghill, the Director of Workforce Race Equality Standard Implementation, who has been awarded a CBE, extraordinarily powerful and well-deserved award, alongside Roger Klein, with whom she's worked very closely in the past, and who has been awarded an OBE, and both of them for their commitment for equality and diversity in the NHS. Again, a particularly valuable award, I think, to Professor Sue Hill, who's our scientific director, who's been made a Dame Commander of the British Empire in reflection of her outstanding leadership on the genomics programme. Neil Churchill, who will be with us today for his dedication to carers in the voluntary sector, was awarded an OBE, and Dr. Nishma Manek, who's a trainee GP and one of our clinical fellows who founded the Next Generation GP programme for emerging leaders, received a BEM. So please will you join me in recording our congratulations and appreciation to those who have been awarded these honours. Right, let me pause there. Any questions or comments on the Chair's report? No, thank you. In which case, may I move on to the next item of business, which is the Chief Executive's report. Simon, over to you.
Thanks, Malcolm. I was just going to very briefly cover two things. First, since we last met, we obviously have the announcement of the additional funding for the National Health Service over the next 5 years, funding which gives us certainty against which to plan and clearly represents a step up in the growth rate of resource that will be available. Over the last 5 years, NHS funding growth has averaged about 2.3% a year, and over the next 5 years it will be 3.4%. So that clearly represents a step change. But linked to that, we are, as the Prime Minister has set out, going to be using the next 5 months between now and the end of November to, with our partners, patients groups, clinical leaders, frontline staff, chart a set of 10-year goals for the National Health Service linked to a 5-year concrete delivery plan. And as part of that, this board is going to have to, at the end of September meeting, make some preliminary judgments about allocations and around some of the financial rules that will need to apply, not just for 1920, but for the years subsequent to that. And we will also be working closely with Health Education England around the linked 10-year workforce strategy, which has got to underpin this, as well as with colleagues in local government and PHE on the question of social care and prevention, which is integral. We expect to be able to, with the Department of Health, make some further capital prioritisation decisions between now and next public meeting, but the larger question of the capital looking out over 10 years will also be linked to the 10-year plan and the budget and spending review process that the government will undertake. But I just want to record my thanks to all of the people in NHS England who worked very diligently to help secure that settlement. And more generally, the second point to make, Malcolm, is that, as everybody knows, tomorrow the NHS celebrates its 70th anniversary, and that's an opportunity to both look back at all of the changes that have occurred, not with a sense of complacency, but with a sense of legitimate achievement, and also, frankly, a chance to thank the staff of the National Health Service, both past and present, and we will be doing that in many venues across the country, not least at Westminster Abbey and York Minster in two national services, but there are many other events going on around the country too.
Thank you, Simon. Any questions or comments on the Chief Executive's report? No. Okay, thank you. And also thank you very much for your extraordinarily hard and successful work on discussions around the financial settlement. So let's move on then, please. The next item on the agenda is developing the NHS long-term plan, evidence-based interventions. I'm going to invite Steve Powers to introduce it. Steve.
Thank you, Malcolm. So I'm sure the board will all agree that where there is evidence of clinical and cost effectiveness, we should endeavour to introduce new treatments into clinical practice as quickly as possible. However, it's just as important that we discontinue treatments and interventions for which there is evidence of ineffectiveness. There are a number of reasons for this, of which I will highlight 3. First and foremost, we should not offer treatments that at best disappoint or inconvenience our patients and at worst potentially harm them. Secondly, we should deploy our most precious resource, our staff, to activities that are of proven clinical benefit. And third, of course, we should use taxpayers' money wisely. The board will recall it recently approved guidance aimed at reducing the use of medicines within the NHS that have limited clinical benefit. And we've now undertaken a similar review of procedures. To do this, we've worked with clinical experts and a number of partner organisations. These include NHS Clinical Commissioners, the Academy of Medical Royal Colleges, NICE and NHS Improvement, and we've also liaised with Health Watch. Our approach has been to identify procedures and interventions where there is evidence of limited clinical benefit. We've derived that evidence base from a variety of sources, including published clinical studies and NICE guidance. And using this methodology, we've generated an initial list of 17 surgical procedures. It's important to recognise that we are not proposing a ban on these procedures. Instead, we are recommending that specific clinical criteria are met before they are undertaken. And we also recognise that many local commissioners have already introduced similar guidelines. However, we know that there is marked variation between CCGs with respect to the numbers of each procedure being undertaken, suggesting that there has not been consistent development or adoption of local guidelines. We plan to encourage implementation using a number of techniques. These range from communication with commissioners and providers to monitoring of procedure volumes and changes to tariff, and Ian will talk a little bit more about that following me. So we now wish to formally consult with the public, patients and clinicians on our proposals, and I therefore ask the board to approve the consultation document. But first, I'm going to ask Ian to add a few comments.
Thank you very much, Steve. We're very mindful that previous ambitions to make progress in this area have not been as successful as we would have liked. So we've been working very closely with our partners to develop a suite of implementation actions that mean the principles that Steve has highlighted will now be effected. And that includes working through and setting activity reduction goals, which we're consulting on formally, ensuring that there is a guiding coalition of national interests to progress this work, effective multi-channel clinical engagement, working with a number of exemplar geographies who will be able to show how they can implement all of these changes at the same time faster than the rest of the country, changes to the tariff system backed by a proposed adjustment to the NHS standard contract, changes to the e-referral system so that we better reflect this as GPs refer into secondary care, constructing a joined-up monitoring dashboard, changes to audit arrangements, consideration of how we reflect this in our assurance systems, as well as the support of the Care Quality Commission in aligning their activity with the programme. Thank you, Steve.
Thank you very much. Can we just perhaps open some of the detail of this? I understand it's very difficult to estimate what might be the cost savings that might arise from this, but and one wonders, is this the first, do you think, of several future interventions at national level which are intended not only to save money and cut out unwarranted variation, but also to improve the quality of care to patients? I mean, I'm trying to get a sense of how the balance of this is. It's about wasteful procedures which are potentially harmful, but to what extent does this paper actually capture the vast array of unwarranted variation that we have across the NHS?
So we started with a longer list, which we have narrowed down to a list of 17, which we believe are the right list to address initially. There are reasons why some of the other procedures or interventions we looked at are not on this list. For instance, around the mechanisms that we might be able to use to reduce variation, which we would need to do further work on, where they are not directly commissioned but are part of a pathway of care rather than an individual commissioned item. So I think this will be the first stage. The same principles will apply that I've outlined. And indeed, as part of the consultation, one of the consultation questions is to ask whether there are procedures that people feel, whether they're clinicians or public or patients, that we should consider in a further round.
Let me invite questions and comments from the board. Michelle.
Thank you. Thanks, Steve. Could you talk us through the data analysis work you've done to understand the impact of these proposals on different communities and equality groups?
Yes, we've done an equality assessment, and we don't believe it will have a significant impact, but I think that's a very important point. And I think we will continue to look at that closely in the consultation period.
Okay.
Can I just pick up on one point? Sorry to monopolise this, but it's the chair's privilege after all. But one point, which is, there has been media comment that this is about cutting expenditure, but my understanding, of course, is this is actually recycling expenditure from activity which we think is wasteful or even potentially harmful to patients and putting it back into the provision of other services.
Yes, absolutely. So my opening comment was for a reason, which is if we do want to invest in clinically proven treatments, and I think the good news is that there are lots of very interesting new techniques and procedures on the horizon, then where there is an evidence base that those are clinically effective and when they are cost effective, we should absolutely be attempting to get those into clinical practice as quickly as possible. And of course, in recycling the funding that we are currently expending on interventions or procedures that are now no longer thought to be clinically effective or have been superseded by different procedures, then absolutely that resource should be recycled through to fund the clinically effective evidence-based procedures that we wish to introduce in the future.
Yes, Richard, and then David.
Just one of the comments you made about this is not about a ban on these procedures. No. What reassurance can you give people that this won't effectively develop into a ban? So the sort of mechanisms for restricting funding, except in particular cases, can people be reassured that will still allow proper clinical decision making on circumstances where these would be appropriate?
So I make two comments. Firstly, clinicians are very used to guidelines. We actually are an exemplar in terms of a country in developing guidelines. I give you NICE as an example. So the concept of guidelines, consensus opinion, which clinicians refer to, is well established. Secondly, CCGs and local commissioners have established processes for reviewing individual cases, and we anticipate those will be used as they are at present in local guidelines. They will be used to affect these processes.
Could I add briefly that one of the reasons why we haven't made as much progress in the past is because there's been a gap between the evidence and the high-level guidance produced and then what clinicians can actually do. So as part of this process, Steve and his team have developed clinical criteria for all of the 17 interventions, working with the professions, which set out the circumstances in which the interventions should and shouldn't normally be applied, quite apart from the question of the individual exceptional cases, and we're consulting on all of those criteria through this process.
And the reason it isn't a ban is because we perfectly accept that no guideline perfectly fits every single patient. And there will always be exceptions where it is quite right and there is a limited evidence base that for a particular individual with a particular set of clinical circumstances, it would be quite appropriate to proceed with that. So that is recognised, that is the skill of the individual clinician in consultation with a shared decision with the patient. And as I said, there will be mechanisms in place in order for those procedures to be undertaken.
Thank you.
David.
So, Steve, first of all, I think this is should be an ongoing process. I know it's one of the questions you ask in the consultation, but it seems to be inevitable that as medical science advances, things will go up and need to be replaced. So I'd personally be very supportive. I think that my most sort of question, I guess, is in virtually all of these instances where, and I'm paraphrasing and sort of reducing to make the point, is that we're stopping a surgical procedure and replacing it with some form of ongoing support or help, which will require different skills, different money flows, and to some extent changes in behaviour in both clinicians but also in patients. And I wonder whether we've given thought as part of this to how we're going to be confident that those things will happen. and that the sort of the saving over here won't just be taken to allow more surgical prevention, and then there won't be sufficient resources in people, capability, cash, whatever, to provide what essentially we're doing, which is replacing with a better, more clinically proven approach. Is
Yes.
that a fair summary, by the way?
It's a fair summary. So I think most of the alternative procedures are already in place, so we are not inventing new approaches. We have netted off in our assumptions, and I think we've been cautious in our financial analysis because we recognise that we are not replacing something with nothing. We're replacing something with something else, which will have another cost profile. And that is why the cost analysis inevitably is a judgment, and we will need to track. But I think those are fair comments.
So for me, the cost approach is secondary to the medical
Absolutely
effectiveness
the case,
and the opportunity cost of talented people.
Yes.
But I guess as we think about the implementation of this, it doesn't. We talk a lot about guidelines and those things which have some effectiveness, different in different places. I'd encourage us to give as much thought as to how we ensure that CCGs and practitioners make sure that the capacity and the capabilities are in place at the right sort of scale to support people for whom we're not offering route A, we're now saying route B.
Yeah, I agree.
Okay, well, thank you both Steve and Ian for the work that's gone into this. I'm going to ask the board, first of all, to approve the launch of the public consultation in terms of the document that we've got in front of us. We're happy to do that. And you might like to say a few words about the processes of engagement and how we can be sure that we're reaching out to not just to the clinicians, but to patients and to public more generally.
Yeah, so we have a section on page 29, I think, of the guidance, at least the version I've got in front of me, which outlines the process for responding to the consultation. So that includes an online web form, written responses. We will be holding events, face-to-face events and webinars. And of course, we will be reviewing that during the consultation process. And if we need to put on additional events or additional processes, we will do that too.
Okay, well, thank you. And we look forward to hearing the outcomes of the consultation in due course and coming to formal decisions. So today is an approval of the consultation.
Yes, correct.
Formal decisions await the next iteration. Okay, thank you very much for that. May we then move on to the next item, Ian, which is the primary care reform papers. Please,
Thank you very much, Chair. So the time is ripe for the most significant discussions about the GP contract since 2004. This is for 5 reasons. First, the long-term NHS plan, which will build on the GP forward view and go further. Second, the ongoing pressures on general practice, including recruitment, retention and skill mix, which Dominic will touch on in the later paper. Third, the nationwide development of primary care networks as an expanding service delivery unit. Fourth, the potential of digital primary care to benefit patients and practices alike. And fifth, the array of different major reviews now underway of the quality and outcomes framework, the car health funding formula, the review of GP premises, the review of the GP partnership model, as well as the government's commitment to introduce a state-backed indemnity solution. And across all of these different elements, we need to create a coherent approach, and that calls for closer partnership working with the profession to develop and agree what could be wide-ranging contract reforms to enable general practice to flourish into the next decade. NHS England has now in-housed the negotiations from NHS employers, and I look forward to working with Richard Vaughtry and his GPC England team to co-design and reach agreement about the main building blocks of reform, as well as making progress for 2019-20. Today, NHS England is seeking to launch engagement exercises on 2 specific facets of the GP contract, the quality and outcomes framework and how we pay for digital-first models. The Commissioning Committee considered both of these in May, earlier this year. In 2017, NHS England committed to reviewing the quality and outcomes framework. We established a dedicated team a structured review methodology, including a thorough review of the evidence base and a broad-based steering group. We engaged widely, and today we're publishing the outcome of the review. And I'd like to thank members of the steering group for their invaluable contributions and advice. It's worth noting that QOF is both an incentive scheme, but it also provides core practice income. The profession has called for it at different times to be scrapped and also for it to be retained. It's led to positive outcomes, but it can also get in the way of GPs providing the most appropriate holistic care. And the review has sought to balance the risks of over-retirement of indicators with indicator reform and the creation of headroom for innovation. And through careful deliberation, the review makes 5 main recommendations: to modify up to half of the indicators to improve efficacy and impact, to update the exception reporting mechanisms to enable smarter differentiation between different groups of patients. Thirdly, to retire up to a quarter of indicators through a transparent indicator assessment methodology. Fourth, to introduce a new quality improvement domain which would utilise points freed up through retiring indicators. And fifth, to run a national trial of a network-level QOF with a select number of sites. NHS England has also reviewed payments for digital-first primary care. Over the next decade, we will be supporting faster, full adoption of digital primary care, and the way in which we contract and pay for care needs to keep up with digital delivery. And that those payment mechanisms need to be fair and be seen to be fair. We conclude from the evidence currently available that there are 3 specific ways that payments need to change to avoid an unjustifiable redistribution of practice income to digital-first models. And these all relate to the geographical relationship between the practice and its patients. So first, the rurality index we think should apply only to patients who live in a practice's catchment area, not all registered patients. Secondly, that the £2.18 per patient London adjustment should only apply to patients who live in London, not to patients living outside London who are registered with a London practice. And third, that the payments for out-of-area patients should not include the costs of home visits, which the practice doesn't have to provide. The analysis and the proposals in our paper are a first step. We freely acknowledge that we don't have the full answer here. We will need to learn and further adapt as we support further faster expansion of digital-first models and understand better their cost structure, patient characteristics, and their impact on wider system utilisation. We would welcome views on both documents by the 31st of August to inform the formal discussions we will then be having with the BMA about potential contract reform from 2019-20. And I asked the board, I think, to do 3 things. First, to note that we're now entering this new phase of contract reform. Secondly, to approve both of the attached reports. And with that, to launch the engagement exercises on the QOF review and payments for digital-first primary care.
Well, thank you very much for that, Ian. I mean, this is, as you said in your very opening comments, the most radical, potentially most radical review of primary care and its funding since 2004. Can I just ask a technical question? You talk in the paper about engagement as opposed to consultation. What are the differences that you foresee in that process?
So we've already engaged fully with the profession and patient groups through the QOF review. There's been a large number of different workshops and events. We've similarly had a lot of conversations around the digital-first process. We're now formally inviting views and feedback on these documents. Before we then go into the process of contract reform discussions, those would then potentially take effect through regulations which the Department of Health has responsibility for implementing.
But we are, in effect, their agent in those negotiations.
We have, I think, the formal responsibility in law to lead agreed on the development of the contract, and we have the financial responsibility and the function, but they've retained the legal obligation in relation to the specific regulations.
Good. Okay, thank you. So let me invite some questions and comments, and I think we can look at the overall and then at the QOF and then at the digital first. But let me start with Noel and Wendy.
My comment, Martin, was really on digital first.
Well,
do you want to take that first?
Shall we go to digital first then?
Yes. Mine was on a digital first as well, actually.
Let's do digital first.
Yes.
Not second. Okay. No.
So we sort of recognise societally that people live complex lives and they don't always want access to GP services in their home, but they also want it in the city too. What is the implication for the 3 tariff reform measures on the marketplace that we want to stimulate for digital services that accommodate complex lives of people who work in cities but don't necessarily live in cities?
The proposals here are intended to support the sustainable, faster development of those models. And they're intended to do that by ensuring that the way in which we pay for patients who are don't have such a close geographical relationship with their patients are fair and sustainable and appear as such, I think, to the outside world.
Noel, are you reflecting?
Well, I was reflecting on the fact that GP choice was designed to enable people to have that mobility of service access. And I just think it's important when we design these policies that we can consider how it affects some of the fundamental principles of what we are providing in terms of service access, but also on the way it's stimulating a marketplace to come forward to provide alternatives to physical channels. So that was my point.
And these relatively technical, specific adjustments do not in any way impact adversely on GP choice policy, which remains exactly as it is.
Chair, can I
Yes, Matthew, please.
Thank you. Because this has been a really, the work that's gone behind has been a really good example of Ian's strategy team working together with my digital team to try and work out what strategy has to look like in the future with this digital dimension coming across it. And I think there is a significant element to this, which is to say, as we move forward and we learn, we need to make sure that the funding flows reflect the changes in the models of access, both in terms of paying digital providers a fair rate, which means not a rate that they can actually operate at, but not also an excess rate, because what we don't want to do is to find that market entrants are only successful for a couple of years, and then when we change the pricing they exit it. So we need to get it fair as quickly as possible, but also to reflect that it's changing the case mix, and maybe changing the case mix for patients who want a face-to-face contact with a GP, and that GPs are appropriately paid for those as well. So this is, as you say, potentially a very big change going forward over the next 5-10 years in the way in which primary care urgent access is provided. Will include digital in it, and we need to be quite agile to make sure that it works for people who want to innovate, but also supports the vast number of people who use primary care, who are elderly, have long-term conditions, and enjoy and find important the personal relationship with a GP that they've got to know over many years. We need to be able to support both services simultaneously.
That's helpful, thank you.
Yeah, I mean, this leads in a bit to my comment. We obviously spent quite a long time on this, Ian, on both the engagements at the commissioning committee, and I think the committee felt comfortable with going forward to get further input, which we would seek. My question on the digital first piece is really about, I think our learning in that experience is there's a lot going on, there's a lot more that's going to go on, and we can only have so much sense of how we'll be able to anticipate the future. How do we create in these negotiations an environment that continues to encourage innovation, as we said, but also gives us the space to be able to not have to relook at these funding models and things every 6 months? How do we develop that with enough flexibility?
So I'd say that the most important thing is that we're really clear as we develop the primary care elements of the long-term plan, where we want to try and get to, where investment is coming, what our ambitions are around change, and then how we line up what the necessary actions are to support that, and then in the light of that think about what the contractual arrangements ought to be. I think we've got an opportunity to have a smarter way of working directly with the BMA as we develop the plan, to understand then what the medium-term contractual changes are, rather than be trapped in what has recently been an annual negotiation cycle where we're looking at relatively modest incremental steps. And part of the opportunity arising from this reset, really, I think, of the relationships is that we can look at the medium-term changes that are needed and then think about 1920 within that context rather than the other way around.
Other issues? David?
Again, on digital, I think the other one we'll come to, but digital first doesn't mean digital only. Is that right? Did I read that right?
Yes.
And how do we... So, to what extent does the... Because I suspect we will see hybrid models start to emerge. To what extent does this set of consultation work for those type of models rather than digital only?
So these three relatively narrow specific changes are changes to the entirety of how we pay for general practice services, including physical only, hybrid models, and digital first only.
Right.
And as we've developed them, we have considered the impact, and we set out some of the impacts on physical only and the hybrid.
I think there's one of the most important parts of the 10-year sort of vision and the 5-year delivery plan will be our stance on how we think about the development of different models, because every other industry tells you going through digital disruption that actually the evolutional pace picks up. And I think to the point that was made before, Wendy's point, we need to be also engaging on the future direction and the implications of that, as well as on getting greater equality and equity in today's world.
Exactly so.
Matthew and Joanne.
It's really just to clarify with Ian that the Cahill model, the funding formula, doesn't allow a digital-only model. You have to be able to access and see a GP through that triage, through that model. So behind these models that this funding formula is talking about, somewhere there is a GP who will see you if you need to see, if that is the right point to get to. That's why it's digital first.
Thank you.
I mean, this is a slightly odd conversation, isn't it? Because we've backed into a really big, important developmental subject, which is multi-channel primary care, through a paper with a very specific purpose, which is to smooth out the unintended consequences of a particular pilot. And I think we just need to keep that in mind. And the bigger conversation is being held within the organisation in different ways, and we haven't ventilated it publicly quite yet, is my understanding. The only observation I'd make is the reason that we've ended up where we are, which is in the public board looking at consultation on this narrow set of changes to smooth the effects of a pilot, is because of the dramatic effect this pilot has had. And I think that it's as well to see that as an indicator of public appetite for this and how important this broader topic is of how to introduce multi-channel, including digital primary care, and what that might look like in the future.
I think that's exactly right, Joanne. I mean, just one additional point I'd make is that we haven't designed these changes solely in relation to the GP at hand service. Obviously, that's the most well-known and has been growing fastest in terms of new registrations, but we've carefully sought to develop this for all potential equivalent arrangements.
I take that. Thank you. That's helpful.
Other observations? Victor?
Just a question, really. I know you haven't these suggestions around the payment system aren't led by this particular pilot because we're still evaluating it. I understand. Is that right? We're still evaluating the GP at hand pilot. At least that's what the indications are.
Yes.
So the question I was going to ask is this the only pilot? Are there other pilots that we're also seeking to learn from? And does this do your recommendations leave room for adjustments in what we plan to do as a result of the outcome of these pilots, including the one in Hammersmith and Fulham? Because one sparrow doth not a summer make, I think is the analogy.
So we are conducting, or it's strictly accurate, the CCG is conducting an evaluation through London Region of the Hammersmith GP at hand model, because it is a significant shift, and therefore which has been implemented not as a national pilot but as a primary care offering developed by the local GPs to the public. And so as a change that is going on in the system, we are evaluating that as we would any other major and disruptive change that happened anywhere. We would want to understand that. The piece of work that Ian's team has done has been to move quickly to say it is clear that you can see early on that this is changing some of the underlying dynamics under which the formula is based, and therefore what is it clear we should act on now. I think we will need to iterate this over time as we learn more, as different models emerge. This GP at hand won't be the only model. We also have we've got 300 practices and 3 million people who have front ends to their GP practice, which are deeply embedded, which are an alternate route as opposed to a digital first route, but equally over time could become significant in changing the way in which practices run. So this won't be the only time we come back to the funding model conversation.
And we haven't even for this consultation, we acknowledge that we haven't looked at the question of the patient characteristics. This is only looking at the relationship of the geography of the practice and the individual patient, and we know there's more work to be done to understand that in relation to all digital first models, as well as the cost structure of digital first models and their effects on wider system utilisation, so A&E attendances, prescribing rates, admissions and so on.
And while I've got you, just a very quick question. Could you say a bit more about what you've learnt about equality and equity in relation to digital first?
So we've undertaken an equality impact assessment, and we don't think that there would be adverse consequences as a result of these specific sets of changes. Victor, I think the bigger question of equalities, I think, will inevitably be picked up more fully within the consideration of patient characteristics of digital first models, rather than these specific narrower changes.
Okay, well, thank you very much for that. I think around the board we understand that primary care, and particularly GP services, are the fundamental building block of a universal healthcare system in this country. Secondly, we also understand that it's under great pressure and under great stress, and we've spent a lot of time over the past 2 years trying to redirect investment into GP services, and this seems to me to be a logical and vital continuation of that. We also, of course, understand that there will be models of digital first coming through, many of them initiated within practices, Matthew, the model that you were talking about, the e-front end, but also there will be a very vibrant private sector looking to universalise digital models of primary care. And I would suggest that behind these rather technical amendments, as you characterise them, lies the more fundamental question of how we combine those two in order to ensure that digital first becomes a model that supports GPs, that reduces workload, that allows greater efficiency and a greater ability for GPs to concentrate on those patients to whom they can provide greatest benefit. So it's part of our looking at GP networks, it's part of our reinvestment in primary care, but also understanding, as I think Wendy put it, that actually change is going to happen very quickly across this area, and we've got a fundamental duty, I think, to ensure that there is continuity of care for our patients that's made increasingly efficient and effective and accurate by virtue of the deployment of new technologies. So I hope that puts the context in which we will go out to further engagement. Can I just, on Digital First, commend the work that you're doing with the BMA and with other stakeholders. I think there's an appropriate, cautious way of picking up some of the perhaps unanticipated consequences of the GP at hand issue, whilst at the same time realising that the funding formula more generally is in need of review. So may we then move to the QOF paper, and let me invite... I'm sorry, just before I do, Steve, did you want to come in on this?
Talk about QOF.
Okay, right, well, may we move to the QOF paper? Steve.
So on QOF, I was just going to say how pleased I was that there will be a domain for quality improvement in QOF. So I personally believe that quality improvement is something that that increasingly is important in our improvement of healthcare and strikes a real chord amongst practicing clinicians and really gets them into a place where they come together with colleagues, multidisciplinary colleagues and managers really to focus on improvement. So my question was, how confident are we that we will be able to support practices in undertaking quality improvement work?
I think it's a great question, Steve. I think we're still at the... Notwithstanding all the work over the last year, we're still near the beginning of the process here. We've got the engagement exercise. We will then have the detailed work of discussing and agreeing the precise changes to the indicators, including, and obviously we'll be looking to reach agreement with the profession that there is a quality improvement domain and that we've got the three elements that we're describing here. As part of those conversations, we'll need to work through the practicalities of implementation, and I think we're all mindful in NHS England, with our national partners, and in the profession, that we have been underclubbed in terms of support for quality improvement, and therefore there will be a need to consider that very carefully as we think through the way in which we give effect to any changes.
Good, well thank you very much. Are there any other issues arising on the QOF paper? Because if not, may I invite the board please to note the report that we've had and approve the reports, but also to approve the launch of the engagement exercises on both the QOF and Digital First. Are we happy to do that? Good, thank you very much. We turn now to item 6, which is around General Practice Services Programme Update. We have a paper. I'm going to welcome Dominic Hardy to the table, who is Director of Primary Care Delivery, and I think alongside Matthew, who will introduce us to the paper. Matthew.
Thank you very much. Yes, and welcome to Dominic. I would just say, in the context of the conversation that we've just had about Digital First, this conversation is to say there is a whole range of pieces of work going on across primary care as the bedrock, and I would argue probably the single biggest driver of why the NHS is the best value health system in the world, is our list-based general practice. And Dominic and his team have been working over a number of years now to help alleviate the pressure in primary care and help move it forward into what the future has, of which a slither of that is the digital piece of it, and so much more of it is real people talking to real people every day. So Dominic, why don't you talk us through what's going on?
Thanks Matthew, and thank you for the opportunity, Chair, to update on the progress. It's timely. We're over 2 years beyond the publication of the General Practice Forward View. We've made some significant progress since April 2016, including in a number of key areas. We committed to significant increase in investment in general practice, and we are on track to deliver an additional £2.4 billion per year by 2021, rising to a total of £12 billion. That investment is helping us deliver across a range of other areas, including in extending access. Well over half the population now have access to general practice appointments at evenings and weekends. That's ahead of our target of around 40% by the end of March earlier this year. That's allowed us to bring forward the timetable for full rollout of this, and so by October 100% of the population should be able to access general practice appointments at evenings and at weekends. We've also sought to improve the general practice infrastructure, and we've now completed almost 1,000 projects to extend buildings and improve them and apply new technologies, including enable online consultations, as Matthew referred to earlier. We've also been able to expand the general practice workforce as a key component of sustaining general practice and renewing it for the future. We had a target to deliver an additional 5,000 additional non-GP staff by 2020, and we've already expanded that cadre of the workforce by 4,500. That includes almost another 500 full-time equivalent nurses in general practice and over 700 clinical pharmacists, all of whom are enabling a more multidisciplinary approach and giving patients a wider range of staff who they can access in general practice. We have a continuing challenge to deliver the other workforce target of 5,000 additional doctors in general practice. Despite an increase in trainees, general practitioner trainees, we have so far seen a net decrease in overall numbers. We continue to work hard on measures to recruit GPs, including from overseas, and the recent government decision to lift the Tier 2 visa cap is going to help us accelerate that work programme significantly, we believe. And we work on retaining general practitioners in the workforce, whether through addressing issues like rising indemnity costs and introducing a state-backed scheme from next year, ideally, and also by bearing down on workload challenges that undoubtedly press on general practice at the moment. Finally, looking to the future, we will not only continue to deliver this programme with vigour, we will also particularly seek to emphasise the establishment of primary care networks as a key means of enhancing resilience in general practice and wider primary care, of enabling the deployment of a multidisciplinary workforce and giving patients a wider range of practitioners and choice around how they access general practice. So I bring this report, Chair, for the board to note and for discussion.
Right, well thank you very much, Dominic, and actually it's very pleasing to see the progress that's been made and on many fronts ahead of forecast, so thank you for that and to your team. Let me invite the board to pose any questions or comments. Wendy.
Dominic, we've obviously spent a lot of time on this issue, and I think that there's a lot of good ideas that have been getting implemented, which brings a lot of the momentum to it. Two issues I have are two questions. One is a continued worry about our GPs and the frontline staff and the administrative burden that, though better, continues to exist for them. Do you think we're doing all we can to really leverage technology and give them the tools to be as helpful as possible in reducing that burden? That's question one.
Yeah.
And then question two, the primary care networks are central to our future. They mean so much for our patients, and they will really be a key element of us transforming care. Are we clear what the largest barriers are to accelerating a greater and a faster shift to the primary care networks?
So to take those in turn, in terms of technologies and how we apply those to ease workload burdens, we have made some inroads. So the Time for Care programme has given a really high number of practices now, several thousand, access to, for example, document management systems. And I visited a practice in Lincoln yesterday who had made really good use of that software and been able to see a really significant reduction in the workload that they'd had as a practice. We also worked with colleagues at the CQC to try and ease some of the regulatory burden that practices face, and the work you've already discussed around online consultations is equally helping some practices address that kind of workload issue. I've heard about practices in Sidcup, for example, that I visited on Friday, who've made really significant progress even in a few weeks and months in applying that kind of technology. There's undoubtedly a lot more to do, and the remaining period of this programme is squarely going to focus on that continued effort. For primary care networks, biggest barriers are not normally around enthusiasm. So we've worked with hundreds, thousands of practices who are pursuing this course with vigour. Often the the need is for some headroom among practices to think about how they like to collaborate more effectively and do that to best effect on behalf of their patients and the staff they employ. So creating some of the capacity, to Ian's earlier point, through people that we can help provide and through financial resources can give them some of that thinking space to make the changes that they need and frankly want to make. But that is something that, as I say, we need to continue to address over the forthcoming couple of years.
So on this, there's been lots of ambition, there's been lots of progress in lots of areas. So I think that's really, really good. The one area where clearly that stands out from this is on the number of doctors working in GP practice. And I guess that's my question for you, Dominic, is what do we understand about the drivers of the lower level of retention? And to what extent does that interact with the work that Ian was talking about a few minutes ago on contract reform? And just what's our understanding on what's happening to retention and why?
So successive surveys and other research, Richard, points to a few key drivers, whether it's around workload pressures and increasing demands, not just by age, but also by complexity and acuity from patients presenting. Sometimes through fringe issues like rising indemnity costs, but also because GPs at the higher end of their experience have generally filled their lifetime allowance in their pension and have almost an opportunity to retire early. And so to that extent, we seek to address each of those issues and retain as many GPs in the workforce as we can, particularly at the upper end where often GPs are at their most productive. Sometimes that can involve seeking to retain those more experienced GPs for fewer sessions per week. That can even mean them operating in a floating capacity across a number of practices. And we're working with all of the STPs and ICSs across the country to support them and resource them to deploy exactly those kind of schemes so that we do secure as many of the more experienced GPs for as long as possible. And in terms of workload, some of the work we're doing that I described in response to Wendy's question is exactly about that, helping practices individually and together bear down on the root causes of that by expanding their workforce and using other skills across the team to supplement the GP capacity that we've got, as well as getting more productive by using technologies, for example, to enhance productivity and workflow.
So on those ones where we can identify particular things like the indemnity issue, we've got work in progress. On things where it's to do with workload, you can do things around sort of reducing bureaucracy and the other things we would target. I guess, and it's one of the reasons I asked about this, the lifetime allowance issue on the pensions. Everything I've heard has been quite a big issue. There's not really a lot you can do about that, or is there? I mean, are there different ways of approaching this that get you into that or not?
So we have had a number of discussions with Department of Health and Social Care colleagues, and we continue to pursue those. We are, as you imply, part of a wider public sector picture here. And so we recognise that this is a wider discussion that needs to happen at the centre of government.
The thing we're finding that has been that is most effective and most transformational is the combination of the additional non-GP clinical workforce and where areas have rethought how they're working. So we do see across the country practices, particularly where they're coming together into networks and you're thinking it bigger than a practice by practice. How do you actually use the combination of new clinical skills coming in, working as part of a team with GPs, and the use of technology and the combination of our best examples to change the working life of GPs, and we're getting some tremendously positive feedback from a whole host of parts of the country now who've gone through that work. Is that fair, Don?
That's absolutely right. The particular challenge we've got is to shift from individual practices, of whom I can give you countless examples, who tackled the kind of challenge of retiring GPs and losing partners from their practice, and that becoming something that happens in a more scaled, wholesale way. Because if we rely on 7,500, no doubt ingenious practices, each solving these problems themselves, that's a very slow way to get to where we need to be. If we can do that through primary care networks and versions thereof, who can do that at greater scale in a more collaborative way, we expect that we could deliver those kind of changes and create a thriving general practice sector more quickly.
David and Steve and Moira.
So, Dominic, last time I asked you this question, you said the answer was the visa problem, which you've solved, so well done. I'll give you the credit. But actually, boards are here, I think, to help as well as to oversee and challenge. So my question is, and it may be that it's a short answer, if you had a fairy, sort of a magic wand, and you could do one thing that would improve the effectiveness of your programme and the workload, I'm particularly looking at workload and retention of GPs, where this board could help either directly or through its convening or its sort of campaigning type of activities, what would that be? What would be the one thing that would make a really big difference?
So I think there are a number of answers I could give. One that I am going to give that I've seen in action recently is the wider application and speedier application of technology and the support for practices to optimise that. So where I've seen the deployment of online consultation systems, it has had a transformational effect on the ability of those practices to cope with the day-to-day workload pressures across general practitioners, practice nurses, clinical pharmacists, and I believe that if we could seriously accelerate that, individual practices would find their daily lives considerably easier.
So what would you need to allow that to happen? Is it sort of more resource? Is it implementation skills? Is it sort of, what would it be?
So I think there are a combination of things. The funding is there. In the paper we talk about the £45 million across 3 years. Probably the deficit we've got at the moment is almost the sales pitch, if I can put it as crudely as that, to practices about the benefits and a corresponding belief about the benefits that can accrue. And also then some capacity, whether through our own local teams or clinical commissioning groups, to get shoulder to shoulder with practices and help them and the suppliers of these products properly embed them and optimise them.
So given that answer, I wonder, Wendy, whether through the commissioning committee or whether Malcolm through the board, because this is, we've all said GPs are the bedrock of the service. Yes. Absolutely agree with that. We all know we've got both short-term and long-term sort of workforce challenges, and we appear from Dominic's skill and judgment to have a sort of something that we could think about accelerating. So I guess my question is, to Malcolm, to Wendy, is can we not as a board encourage that through suggesting that we should ask Dominic to come back at some stage and say, with broader skills, this is what we're now going to do, and recognising Simon and Matthew and others supporting by making necessary prioritisation decisions.
Why don't we put that
raid
as a
Mr. Bauman's pockets?
Wendy, if you're happy, I think that comes through commissioning committee, but should come back to board.
Yeah, and I mean we are on that. That was a little hidden news behind my question, because I think that is so central, and I think that's well taken and en route as well.
It strikes me, Simon, as something where we could make a material difference in a very short period of time, putting pressure on.
Right, well, we'll take that forward as an action item. Let me invite Steve, Moira and Jane.
Well, it was really to support and emphasise the point that both Matthew and Dom made in answer to Richard's question around what were the drivers for poorer retention, and I believe, and my experience is, that scale offers a solution to many of those issues, and I think that's why the development of primary care networks, which you mentioned at the start, is so important, because that gives a flexibility within a group of practices to deploy additional staff to offer a flexibility of return to work, which is not so easy to do in smaller practices.
Thanks, Malcolm. Lots of good things to report, Dominic, but obviously Rich has drawn attention to the decrease in the number of full-time equivalent doctors. generally under-doctoring has impacted more on more deprived areas. And we've, my colleague here on my right has regularly drawn attention to the inverse care law, and I wonder whether there is any, with the things that are working well, whether there is any change to that impact, disproportionate impact on deprived areas, or is it getting worse?
So we've had some success, Moira, in being able to deploy GP trainees to areas of the country that have found it historically hard to fill their training places. We've paid targeted enhanced recruitment pot of money to trainees of £20,000 a time to go to those areas, and there is some evidence via Health Education England that trainees have then stayed in that area. So there is some soft evidence, I would say, that we're starting to get to grips with all of that. But we continue to need practices and their trainees and CCGs and local offices to work incredibly hard to ensure that those trainees are offered opportunities in the patch in which they train and then stay. I was in Lincolnshire yesterday, as I said, and they clearly have a good deal of work to do to ensure that happens. They're clear what needs to be done, but the scale of the challenge is considerable, because this is not something that we've tackled effectively, being able to secure our trainees full stop, and then in the areas in which they train. The opening of 5 new medical schools, including one in the University of Lincoln, will help that, but it will still need the whole of the system to work together to best effect to get the kind of impact that we're looking for and bear down on the under-doctored challenge that we've got and the consequent inequalities of access.
Jane.
I think just wanted to build on what Dominic was saying about GPs. I think I completely support the plans and the actions that we've got in place, but general practice is wider than GPs, and we know from experience that actually using and having advanced paramedics, physiotherapists, mental health therapists, clinical pharmacists, nurses working in general practice can actually have a very positive effect. So I think, as well as spending quite a significant amount of our time looking at how we can support the GPs and also recruit and retain more, I think it would be good for us to look at the wider workforce, and we can address some of those shortages much more quickly. We are doing work around general practice nursing, as you know. It is a significant area where we are facing a significant reduction of those nurses in the future, and there are some very straightforward things which may take a little bit of time to get through, but things like terms and conditions, employment models, etc., are very, very different across the country. And I do think we've got some opportunities to do some very good work, and it will make a big difference to the lives of GPs and patients if there is better access to advanced practitioners who are not just doctors.
I think on that note, if Suzanne Restrick were here, who heads up our allied health professionals,
that's why I mentioned it.
She would be very strong on that, and also emphasising the fact that so many allied health professionals are frustrated by the limits to what they're permitted to do, and by their capacity to grow into the much more into the sorts of roles that you've just outlined. Steve?
And not just Suzanne, because if Keith Ridge was here, he would say the same about pharmacists, which Jane has mentioned, and we are deliberately putting more pharmacists into general practice to deal with issues such as polypharmacy, to think about how we increase rates of anticoagulation amongst patients with atrial fibrillation to prevent stroke. So I absolutely agree with Jane. This is around the primary care workforce and not just around the general practitioners.
And of course, much of that engagement with allied health professionals and other professionals is, to some extent, a function of scale. And I think the GP networks are an enabler to be able to employ a broader workforce across a larger population. So, are there further issues to raise with Matthew and Dom? No? Well, thank you, by the way, really good. I think you get a sense that the board would really welcome further updates and developments on this. We're taking a very close interest in it. It's been done, I think, very carefully within the commissioning committee. But this is work that deserves a broader discussion around the boardroom table. We've got some specific items that we will take back through commissioning committee and work closely with you and the team. And Wendy, I know, will pick those up. But on behalf of the board, thank you for all the work done.
Thank you.
Thank you. Okay. May we then move on to the report that we have from the Empowering People and Communities Task Force. This is the second progress report. Victor is chair of this, but I'm going to invite Jane to kick off, and then we'll move on from there. Jane.
Thank you very much,
I should welcome Neil.
Being joined by Neil. Thank you. So I'm just going to say very little, actually, because I think it's probably more important that we listen and hear from Victor. But this is the second update on the work of this task force. The board will remember it's time limited. We set it up to last until the end of December, with some very specific objectives and work. And this report just provides an update on sort of three key areas. And I think probably one of the most important ones of those is the new public participation dashboard. But it also talks more about the work we're doing to improve our partnerships with the voluntary sector, but also lists some of the improvement that we feel we need to make and some of the objectives we've got to do that. So it is making progress. We are finding very good links with our national priorities, and it's really putting a good focus on that. So I'll hand over to Victor, I guess, who I think would be able to, who chairs the task force and will no doubt be able to tell us a lot more.
The first thing I should say is I should thank all the people that have come to these sessions, because the way we operate the task force is quite different. We engage a number of patient groups and interest groups around the areas that we've looked at, cancer and mental health, and things like co-production, and I think it's important to thank them because some of the insights have been directly as a result of their input, so I'd like to do that. Of course, Michelle might want to say a few words as well as my co-chair. Basically, brilliant job, thank you, Michelle. The dashboard paints a picture actually which we should be reasonably pleased with. You know, we in terms of our the board's legal obligations under the Act, where we are not doing so good, I would surmise it's because we haven't accepted or haven't engaged fully with the notion of co-production in the delivery of health and social care in these areas, and using the systems that we've got in those areas to do that. And in light of the 10-year plan, we do know that co-production is more likely to obtain more sustainable health and care services and indeed better financial outcomes. Moving on, we have, across the work that we've done in cancer and mental health, without going into a lot of detail because it's in the report, the thing that strikes me across both of those is the notion even inequalities and inequity, which I'm grateful the board have taken on some of those insights, and I'm also grateful for the leaders of those programs who've responded well to the letters describing those insights to the committees. I am still personally, I guess, but I think Michelle would back this up, still concerned about the responses in programme to some of the observations we've made about cancer. I'm really pleased that in mental health, for instance, we have a date for the production of data on a minority ethnic experience of mental health programmes to date. I think that is quite important. Moving forward, we will be producing a more detailed recommendation report to the board on the relationship with the voluntary and community sector. We have quite high ambitions for the relationship between the NHS and the voluntary and community sector because we believe, and the sector is telling us, that they could do a lot more to deliver the ambitions within the plan. So we'll be coming forward with specific recommendations that lead on from the notes in this report. We'll also be looking at frailty, and I can thank Noel for raising this issue quite some time ago, actually. But we'll be looking at frailty and the use of patient experience data in strategy decision making, because we've got a lot of data. The question is, how do we turn it into information that helps strategic decision making? And looking forward, we have some options as to what we might look at, but we may well revisit the cancer work and look at primary care or learning disabilities. And given that the task force will finish in December, we'll also be thinking about what the legacy is and how it plays into the new structures and ideas around the 10-year plan and NHSE and NHSI. I don't know whether Michelle would like to add anything to what I've said, or indeed Neil. congratulations again on the goal.
Thank you. I think just to draw attention to a couple of the improvement priorities, I think, which came through both for NHS England and for CCGs, one of which was around telling people what has changed as a result of their involvement. And so generally I think there's a story being told around the practice and it is actually very good. This is now part of business as usual, but we haven't done as much as we should to tell people what's different as a result, and that's one of the things that's important in building people's confidence and engagement continuing. And I think a second improvement priority, as Victor has said, is to make sure that we are more proactive in listening to voices which are otherwise seldom heard and involving them in our discussions, where probably we're not doing as well as we would like to be doing. But on the whole, I think Victor agreed that the story is a pretty positive one, and we will have new data published soon, and we can see how it will have changed year on year.
Let me open it up then for discussion. Where shall we start? With Noel, please.
I'm delighted, Victor, you said we have high ambitions for strengthening our engagement with the voluntary sector, and it seems to me extremely important we do so in areas like ageing and mental health and diabetes. And I'm just interested in, so I can see that we're coming forward with recommendations on how to strengthen that in the next phase of the work. I'm just interested in what you found in this work were the principal reasons why we have not engaged so strongly in the past in leveraging the power of the third sector to help us in some of our delivery challenges.
Do you want me to answer that? To respond? I mean, firstly, I think the experience is patchy. Certainly in mental health, there is a good story. The development of the mental health plan was done not only with 20,000 engagements or contacts with people, but also with a number of high-profile voluntary organisations. The same can be said for cancer. The question might be, to what extent have we structured our engagement with the voluntary sector to ensure that seldom heard voices and seldom heard members of that sector actually impact the programmes. And I think we've got somewhere to go on that, and which is why we've been talking about, and it's been a real debate about what principles might drive the next step in that. The second challenge I think we have is the go-to point. So there are lots of players in the sector, both individuals and organisations. Who do they go to in NHS England or NHSI for that matter, and how do we organise ourselves to get them to actually organise themselves so that we have single points of contact on key strategic issues, and how does that drive help us move the needle in the areas of our concern, because the voluntary sector is often seen as a nice to have. It's a bit like kissing babies. Nobody's going to be against it, but it doesn't actually. It's not actually seen as a measurable partner in the way that we do strategy, and that's missing out. So I think those are the things that we need to focus on. I would say that if we're going to move the needle on inequalities and inequity, and I use those two words deliberately, they're not the same thing, then in key areas of the country we are going to have to partner with when that's the voluntary sector, I'm being careful because the social enterprise sector and the charity sector are not the same thing, but we are going to have to partner with not for dividend, for want of a better term, and not for profit organisations in a much clearer way than we are doing at the moment.
That's very helpful. Thank you. Michelle?
Just to build on Victor's points, what we also see, Noel, is a significant diversity of relationship at a local level. So the King's Fund published a report recently which described those very different experiences where the relationship and contribution of the voluntary sector is valued at a local level. There are very mature relationships, and as Neil pointed out, some of the work in a number of local areas is really excellent and genuinely partners in the transformation of care. But it certainly isn't that across the country, and building that good practice locally is critical. The other points to pull out is one, really looking forward to the work that James Sanderson will bring forward on personalised care. And I think that is a particularly important area of work where there's great interest within the voluntary sector. And also looking at how the voluntary and community sector can work as part of the embryonic proposals for an assembly. So there are a number of moving feasts where there's some great opportunities to continue to make progress.
We are making recommendations on both those things. I would just say one last thing, if I may, Chair, which is that in the development of ICSs and STPs, there is a risk that the good work that we've done isn't embedded in the way that we do population health, and it's just a question for how we embed those new structures of population health and ensure that we take those learnings with us.
Thank you, Victor. Michelle, other comments, questions? That point will need to be picked up, of course, about how these processes are embedded as we develop the STPs and particularly then the ICSs. Right. I detect that we've had a very good presentation. Thanks again to Neil for your work on this, and to Victor and Michelle for your co-chairing of the task force. And we will, of course, have another report at the end of the year, in which it will be a wind-up, but as you suggested, Michelle, also leading into thinking about the Assembly and the function of the Assembly. So it strikes me that there is a good coincidence of timing between the task force and the next stages of this important part of the agenda. Okay, well, thank you everybody for that. We're going to move now on to item 8 on the agenda, which is our report on next steps on the NHS 5-year forward view. What are we doing, Matthew? And how are we doing, Matthew?
We're doing a lot, you'll be pleased to know. Just to run you through some of the highlights from the report. Urgent and emergency care, A&E performance was improved to over 90% last month, and looking across the wider pathway, we saw the number of delayed transfers of care has fallen to is now 18% lower than it was at the same time last year. And that's 1,812 fewer detox than when we set the baseline back in May 2017, which is a tremendous effort by the NHS and their partners in local government. And we continue to press on reducing the number of detox in hospitals and making sure that patients receive the appropriate care in the right locations, rather than having people in hospital when they could be receiving more appropriate support elsewhere. We are on track to hit our commitments to put mental health liaison teams in A&Es, and there were 1.4 million calls to NHS 111 in May. That's a nearly 80% increase on May in the previous year. So when we think about the change in the nature of access to services, we also need to be thinking about the changes in 111, the number of people who contact 111 and now get clinical advice from that, the extent to which we are managing to solve people's problems through those phone calls in order that they don't need to be handed off to another part of the system. And I think that's a tremendous increase in our the set of channels through which people can access urgent advice and urgent support, alongside our continued rollout of urgent treatment centres where people can go to get urgent access to primary care services. In terms of the priorities going into this year, we have an even bigger focus this year on demand and capacity across the acute sector, and you'll see at the back of the report the extent to which we are looking at developing our how do we make sure patients don't end up in hospital unnecessarily? What are our series of offers to patients? How do we make sure that patients don't stay in hospital longer than they need to? And how do we get them discharged to the right locations? And now a growing effort and focus on length of stay, the patients who are in hospitals for very long periods of time, over 3 weeks, and how we improve the flow through hospitals to get patients discharged more quickly. Primary care, We're now, as Dominic said, at 55% of practices offering extended access across evenings and weekends, which is ahead of our target and for this point, and on target to get to 100% of the country by the end of the year. We are, and I should just touch on cancer as well, where we've seen the 62-day cancer performance dip in the last month, having improved very significantly the month before. That was predicted in terms of what the Cancer Alliances were expecting, but there's still an enormous amount of work to get us back repeatedly and sustainably onto the 62-day target. Just touching on elective care, we now have just over 4 million patients on the waiting list. That's a 6% increase on this time last year. There's a lot of focus, particularly in NHS improvement at the moment, on the work we need to do in order to stop the waiting list from growing. I think that's a significant effort that's going to be needed this year in order to turn that upward trajectory around and hold the waiting list constant before we start to improve it again. We've talked a number of times at this board around about STPs and integrated care systems, and we're pleased that we've been able to announce the next 4 integrated care systems to be launched in Gloucestershire, Suffolk and North East Essex, West North and East Cumbria, and West Yorkshire and Harrogate, which is a sign of the way in which systems are coming together to address challenges in partnership across primary care, social care, community services, mental health and the acute sector, thinking in terms of their population needs. And I think that is proving to be a very powerful driver of integrated change. And then just lastly, to touch back onto IT, we've now launched the first 5 Exemplar projects for our local health and care records, which will be London, Manchester, Wessex, West Yorkshire and the Thames Valley area. I think those are crucially important IT projects in terms of bringing together the information for patients for their direct care, so that wherever they contact health or care, the information that the person who's supporting them needs is available. So that will include information coming from GPs and hospitals and community settings and social care in order to give us the ability to provide care in the right place rather than patients needing to go to where the information is. And kind of in the medium term, I think that is one of our key strategic steps forward as we look at redesigning services around patients. So a great deal going on at the moment, Malcolm.
Great. Well, thank you very much for that. Can we then invite any comments or questions to Matthew? Yes.
Pick up in the annex to the paper, I wanted to just highlight the results of the impact of the Vanguard programme.
Before you, can I just explain that there's been an issue about the distribution of that page. So it's on our public website, but it's not up on BoardPad unless Leslie been able to do it just now. But please, can you feel free to talk us through it?
Okay, so reducing emergency admissions was the main focus of the 23 MCP and PACS Vanguards. And we now have the complete time series data for the period of the Vanguard funding, and across the duration of the programme, between 2014-15 and 2017-18, emergency admissions grew more slowly on a per capita basis in Vanguard areas than in the non-Vanguard areas. This information was, I think, first published in the recent NAO report. It showed that it had risen over that period by 0.9% across the MCPs, 2.6% in the PACS, and this is compared to 6.3% in the rest of the NHS. And we can confidently say that the result is statistically significant, bearing in mind data quality issues. We've also seen a bigger reduction in relation to the care homes Vanguard. They've held emergency admissions flat during the period, whereas there's been an over 8% rise in admissions for care home residents across the non-Vanguard areas. And then finally, I'd like to flag that the Vanguards have reported through, and this has been through an NHS England assurance process, that they're making very good strides in against their return on investment plans. They're achieving 90% of what they were intending, and this equates to a return of £2 for every £1 spent.
I think we just have to commend the extraordinary work that was done on the Vanguard's programme, and those results, which, as you say, are not statistically insignificant. I mean, these are, I think, a model of how we anticipate a rollout around integrated care across the country. I mean, what's particularly notable to me is what you say about the care homes, because it's not a particularly complex model to establish around the country. How do you see that rolling out over the next 2 or 3 years in the broader context that we're now working in?
So we've already seen very significant spread of the care home model. This board took a paper a little while ago with the 20 evidence-based components of that framework, and through the work between Matthew's team and mine, that is being supported, wider spread of that is being supported. We have data from CCGs that shows their level of maturity in completing aspects of that framework, and we're seeing very significant uptake of that. I'd particularly like to highlight the importance of 2 facets of that, one of which is having a single GP practice per care home, and there's a little bit more work to be done on that. And the second is the role of clinical pharmacists actually working directly in care homes to try and tackle things like contraindicated polypharmacy through regular medication reviews. We have a dedicated programme we set up to support national spread of this, and we're directly funding over 200 pharmacists to work in care homes specifically to solve that problem, and that, I think, is already having an effect.
Visits that Wendy and I and others have made to care homes, that was a really critical part of reducing actually reducing unwarranted admissions to hospital on the grounds of adverse drug reactions, by getting to the root of the polypharmacy programme. Can I take any further? Yes, Jane.
I just wanted to add something to what Matthew talked about when he was mentioning the need to reduce length of stay and our concentration on people that have been in hospital beds for a long time. Some of the board will be aware of the End PJ Paralysis campaign that we've been running, which as a social movement, which is largely led by nurses and allied health professionals. It's a UK-wide one, but it's got multiple engagement across England. And we started it in the middle of April, and we've been collecting data up until the end of June. And I just thought, I mentioned this yesterday at the conference I was doing for nursing, Celebration in Nursing, over the last 70 years. But in that time, across the UK, we had 660,000 patient days where patients were up and out of bed. And of those, 90% were dressed in their own clothes. And that might seem, I mean, it's a great number, but the question people might ask was, well, so what? The big difference is we've now got a timeline of data, and we know we're doing a bit more detail on it to see whether there's causation as well as correlation, but there is a very clear showing where we see length of stay of over 7 days and over 21 days where it's beginning to reduce. And anecdotally, we're seeing reduction in falls, reduction in pressure ulcers, reduction in patient complaints, and we're hearing quite a lot of stories of people going home earlier because they feel better, they look better, and we've had evidence of people saying, well, it's a Saturday morning and you're up and dressed, would you like to go home, rather than waiting till a Monday. So we need to do more data analysis. We're waiting we're going to keep the data collection going until the end of this month. We're also looking with colleagues that have set this up to actually track things like falls and pressure ulcers. But it would appear that this, what is a relatively straightforward piece of work and is actually having a significant impact on the length of stay of patients in hospital, and that's got to be good news. So I just thought it was something that was a really constructive, positive thing, and on behalf of me and the rest of the board, I would like to thank all of those staff that actually tried something new and have really led this with huge dedication and commitment, massive impact, and the pictures of patients in their own clothes, smiling, feeling better. Some of the quotes we've had have been phenomenal.
I mean, it is deeply impressive, those of us who have seen some of this. It's an extraordinary change in culture.
It's been brilliant, absolutely brilliant.
Yes. Right. Are there any further issues on Matthew's report? And by the way, I've now noticed that your Vanguard appendix is up on BoardPad, so we can look at the data in our own time. Okay, I think we're done. Thank you very much on that. Paul, may we move on now to the consolidated month 12, 2017-18 financial report?
Not necessarily.
I've got the wrong heading. I've got the wrong heading on my notes. Yes.
Yeah, accountants are forgiven for being 1 year out of date. But,
well, you can do month 2. Shall I cut out the 1?
Yes, month 2 would be a better thing to talk about. So in the report you have in front of you, we've set out in paragraphs 2 and 3 the position on the Commissioner plans, which have been developed for 18-19, the expenditure profile across the various types of activity. And the good news is that the Commissioner plans, as they stand, have a balanced position at the bottom of them, which is clearly what we are committed to deliver for the year. As you look at this report and just comparing to last year, we need to remember that the complication of the system reserve, which we had last year in looking at any of these numbers, does not exist in 18-19, as all of that money has been deployed up front to the front line. So in 18-19, reporting for the commissioning sector is very much a case of what you see is what you get, rather than this is what we report and there's a separate reserve somewhere else. That's just really important, I think, in contextualising what we then say about what the numbers tell us. Turning to the financial position as at month 2, as is customary at this early stage of the year, there's little, if any, variance in CCG or indeed direct commissioning numbers, and I wouldn't actually read too much at this stage into the small variances that you can see on central costs and technical items. Of potentially greater significance is the risk assessment, which I've set out at the back end of the report, which obviously comes from the process we run alongside the core forecast month in, month out. This is currently showing net risks in the CCG sector of 325 million, which, as I pointed out in the report, compares with 443 million at this stage last year. And there is also a risk of 84 million in NHS England's commissioning budgets. As you would expect, we are working intensively with the affected organisations to manage these risks, and I don't perhaps need to say to the board that we remain committed to delivering financial balance overall as a consequence of that work. At this stage, that's about as much as I can say. I would promise a slightly more interesting and exciting report, possibly in the right way, in the next meeting in September, Malcolm.
Thank you very much, Paul. Not too exciting, I hope. What we look to you for is bland assurance and underpinned by great intelligence. So we look forward. But thank you for the assurance on this occasion. Are there any questions to Paul? No. Well, thank you very much. You passed the test. So let's go on then to board committee annual reports. We've got a series of annual reports amongst the papers today for commissioning committee, investment, with attached terms of reference to approve, specialised services, and from ARAC with attached terms of references to approve. Can I just invite the chairs of those committees whether there's anything they wish to add to what we have in front of us? Wendy?
No, I think it's a complete record.
Thank you. Moira on investment? Thank you very much. Noel on specialised services?
No, I think it's well set out.
Thank you very much. And on ARAC, Joanne? Good. Well, thank you very much, and thanks all. Actually, this is the time of year to thank all the chairs of those committees, including David, who previously had responsibility on commissioning committee, for the work that they put into it and for the close working that they undertake with the teams. May I then turn to the reports from the board committees, updating us on what they've been doing recently. Wendy on commissioning committee?
I think it's in the paper.
It's in the paper. The board has just asked to note the items in your report relating to directions to CCGs and to special measures for CCGs.
Yes, and so 2 points. It's one, it's directions for North Somerset CCG, South Gloucestershire CCG, the removal of those directions, and the removal of special measures for NHS Great Yarmouth and Waverley. as well as NHS Redditch and Bromsgrove, which is great news, and we always like to see progress being made. The other point to note in the board is we have spent a lot of time on digital, as referred to earlier, and we're suggesting that the board have a broader digital development day, which we've talked about previously.
Good, thank you very much. Joanne, on audit and risk?
I don't think there's anything to add, thank you.
Okay, well, thanks. Then I just need to invite the board to note the committee updates. We turn to any other business. I have no other business, I think, except to, of course, commend to the board the enormous amount of public and media interest that there is in the 70th anniversary of the NHS, and the great privilege that we have as a board to be in office at this important time, and to be able to participate in a lot of the celebration that takes place, I have to say, not of our efforts, but of the efforts of those who work across the whole of the NHS, which again we this morning would wish to commend. And on that note, if there's no other business, I'll close the meeting. Thank you very much.